All right, Cheryl, take it away whenever you are ready.
Thank you, Katie. Hi, everyone. Welcome to our regular Finance and Revenue Committee meeting today. We're going to start with roll call. So I'll hand it back over to Katie.
Thank you so much. And I will start with Cheryl Ramirez.
Here.
Richard Gibson.
Here.
Jeff Goodman.
Here.
Chris Hogan.
Here.
John Santa.
Here.
Charlie Swanson.
Here.
Thank you so much. So we're just missing Bethany Stairs and Fenway Chi. So I haven't heard if they can't make it, but we can still move forward without them.
Katie, who did you say was missing besides Chen Wei?
Bethany.
Okay. All right. Thank you.
Mhm.
So now we'll review the agenda. So we're going to start with a summary of the feedback from our last meeting. Jenny's going to go over the feedback that was captured. If we've missed something, please feel free to speak up. Then we're going to wrap up the health expenditure discussion for now. So for this agenda item, we're going to hand it over to Charlie. And I think you guys got Charlie's slides, I believe. I think I saw those. And then, so we'll be ready for the board's review of our straw proposal at the February 20th board meeting this Thursday. So what we're asking the board to do, just by way of a reminder, is to confirm our recommendation to use 2023 as our cost base year and 2030 as the modeling year. And then Charlie is going to be with me at the board meeting to help respond to questions from the board on the straw proposal. So thank you, Charlie, for doing that. Once we have the board's input and our actuarial consultants are on board, then we'll take this work back up. And so today, Charlie's going to finalize that discussion on expenditures for now. So the next agenda item is to review the task force revenue recommendations, and Janine Smith from HMA is going to join us again to provide a review of the work the task force did on revenue and their recommendations. And then we can decide, well, then we're going to discuss those task force revenue recommendations, and we'll hopefully move into some decision points on whether we are going to support those recommendations, or if we want to decide to discuss other new revenue options to consider. And then last, we'll do meeting reflection, next meeting topics. We're going to spend some time looking at the timeline of the committee to see where we're at and where we need to go next. So we'll look at the work plan task list. And then public comment. I don't know if there's any public comment or not, and then we'll adjourn. So that's the agenda.
Cheryl, and just a heads up, we do have one person to share public.
Okay, thanks, Katie. Could we go back to the last slide? So here's a reminder of our timeline. We'll be moving on to the revenue options by looking again at the task force recommendations for the new revenue sources, and we're pivoting from expenditures so that we can catch up with our revenue work before the consultants come on. At the last meeting, we did discuss bringing in a panel of speakers to discuss administrative costs for various healthcare entities. And I'm going to suggest that we make this the topic of our supplementary meeting in March, if we can get those key informants, so to speak, there at that meeting. Does anyone have any recommendation on who the staff can reach out to invite to speak with us on administrative cost savings? And if you don't have the name right now, you can certainly share those recommendations to the staff by email, and they'll work to make those arrangements. But that would be, can you remind me, either Katie or Jenny, when that meeting would be in March? That what the date is? Have we got that scheduled yet? I think we do. It'd be like in about 2 weeks, I think. Does that sound right? Yes, okay. Thanks,
Sorry,
Katie.
yes, March 18th.
Okay, March 18th?
Yes, the months actually, this month and next month correspond exactly in terms of the dates. So all of the days of the week are the same. So March 18th, yes.
So the admin costs wouldn't be a supplementary meeting, it would be on the 18th that we would be talking about that?
So you have a meeting scheduled on the 4th and on the 18th.
Okay, I was thinking we were going to do the admin costs at the supplementary meeting, is that not right?
Admin cost is the supplementary meeting. I'm sorry, I don't know your normal meeting schedule because I haven't done these before. Is the normal meeting the 18th and the supplementary is the 4th?
That's right,
If
yes,
we could find the consultants and bring them in,
by
certainly
March
we could do
4th.
that on the 4th. Yeah.
Okay, so that'd be the goal then, to do it. Okay, all right, thanks. John?
Yeah, I'll send you some suggestions, via email.
Great, thank you so much. Okay, so I think where we're at, oh, we can look at this too. So here's where we are, and I'm assuming the green is what we've done. And so the blue is what we need to do yet. So as we just talked about, we're going to come up with the best estimate that we can of administrative savings. And that's the goal for the March 4th meeting then. And so we'll spend some time. I think the yellow might be what we're doing today. Okay. And then we've got the other 2 blue boxes. So with that, I'm going to hand it over to Jenny to talk about or to review the summary of feedback from the previous meeting.
Thanks, Cheryl.
Oh, Charlie has his hand raised.
Oh, go ahead.
Yeah, could we go back to the previous slide? So the second item, identify current health spending sources that can be transitioned to the universal health plan. We've kind of talked about that, but I don't think we've gotten into enough detail on that to be comfortable with what we've done so far. So I would say we still have that work to do. But that's also intricately connected with revenue in general. So I'm not sure there's as much we should be doing before we talk quite a bit about revenue. So that'd be my thoughts on that.
Yeah, we can revisit as needed then. Okay, so Jenny.
So the summary of feedback, as Cheryl mentioned, the committee is submitting its first straw proposal to the board, and the board will be meeting this Thursday from 9 a.m. to noon, and they'll take up the straw proposal during that meeting. As we also mentioned, the committee would like to bring in professionals. John, thank you. Anyone else who has recommendations on who we might want to bring in terms of healthcare administration to talk about administrative costs and administrative structure, I would be happy to reach out to those individuals. Just send me an email and we will get in touch. You can use the info email and Katie and I will take a look at that and reach out to whomever we can find. The committee would like to speak with a representative from PEB and OEB to learn more about their expenditures. I will be looking into that to see if there's someone we can identify. There are committee members who would like to consider sales tax in addition to the other revenue options. I know that was something that you spoke about briefly during the last meeting, that we didn't want to just push sales tax aside, that there are a few members of the committee who are still interested in exploring that. And the committee would like the Community Engagement and Communications Committee to get input on the revenue plan once it is drafted. That is part of their work plan and part of their tasks to do once something comes out of finance and revenue. They will be taking that out to the identified parties from the legislation and getting some feedback to bring back to the committee and the board. Did we miss anything, or does anybody want to ask questions or clarify any of the things that we are working on in terms of the feedback from the previous meeting? Okay, great.
Jenny. So now I'm going to hand it over to Charlie to give us an update on the health expenditures estimates. You may have seen the spreadsheets and the slides already, so you might have questions. I just want to thank you for your work, Charlie, and the support from the other committee members as well. This was a lot of work. And I think we've come to a really good place to share these parameters with the consultant who comes on board. So I'll hand it over to you, Charlie.
Okay, so I will say that I do have an updated spreadsheet with, and I'll mention some of the changes in there that I will hopefully be sending on to the Finance Revenue Committee, and also for the purpose of the governance board as a whole on Thursday, that I think it would be better for them to be looking at the new spreadsheet to the extent they want to look at it. So next slide. So one of the things that I've added to the spreadsheet is a breakdown of the sources of I guess the sponsors of the various funding streams. I've broken it down into federal, state, and local. There's some question about state and local. It's sometimes hard to decipher that, and I'm pretty sure that I'm missing some local expenditures, because although most of the expenditures that county health departments make come from federal and state sources, there's some from local sources, and I have not yet completely identified that. So there's some question there of exactly, the state and local breakdown there. One of the probably more important pieces is I've broken out the private employer and individual portions of employer-sponsored health insurance. I will say that the data that you see on this slide is primarily using national ratios of the private employer and individual breakdown of employer-sponsored health insurance. But my new spreadsheet does have more Oregon-specific information from MEPS, the Medical Expenditure Panel Survey. So, and it turns out that Oregon has greater participation from employers and less from individuals on average. So for example, that 4 billion from employer sponsored is probably closer to 3 billion in Oregon for individuals. So that the new spreadsheet will have that updated information. You can go on to the next slide. So for the other third-party revenue, first of all, there's not that much. The expenditures are not that great, and that has not been as carefully broken down as what you see above. And then I've also listed down below things that I expect are mostly unaffected by the Universal Health Plan, but I've also provided some comments that I think some of them still need to be thought about. Like worksite health, maybe it just left as it is, or maybe we can estimate how that would change, but it's something that maybe should be thought about. The workers' compensation is probably going to remain, and same also auto, property, and casualty insurance is probably going to remain pretty much as it is, but for provider administrative simplicity, I would expect that the way it should run is that the providers will be paid by the state plan and the state will try to recoup the money. But again, that's something for the board and operations to think more about, I think. The school health is another item that for the most part probably will be left alone or maybe enhanced, but it could potentially be something for the board to think about. So those are comments about things I don't think that we need to worry about trying to raise revenue for, but it's not completely clear at this point. So go on to the next slide. And these are things that I'm pretty sure we don't have to deal with. So Department of Veterans Affairs, Indian Health Services, research, state hospital, corrections, and then also out of pocket for other non-durables, which is mostly the things that people just buy for their own personal usage. So that's just among the total health expenditures in Oregon, just to kind of complete the picture here. Go on to the next slide. So these are this is just some of the information that's of interest, perhaps. Oregon, compared to national plans, has a substantially higher employer-sponsored expenditure ratio than the nation. For the individual marketplace, we're right about at the same amount as the rest of the nation. For Medicare, we are very, very much lower, especially in fee-for-service Medicare. We have much lower expenditures per fee-for-service member than the national average. And in Medicare Advantage, we're somewhat less, or 90% of it. But for fee-for-service, our expenditures are only about 68% of what national average expenditures per fee-for-service Medicare beneficiary. Medicaid, we're quite a bit higher than national average. So those are, I guess, numbers of interest and to keep in mind. And that's part of why in Oregon, Medicaid is not nearly so far behind Medicare as it is in most states. And Medicare is way behind private insurance, much more so than in most states, as far as what providers get paid. Next slide. Okay, that's it. Thanks.
Sure.
Charlie, would you please go back to your first slide? I just want to point something. Yes, this one. Because I've been looking at these numbers for a long time, but it really struck me. I want to make sure the other members on the committee realize this because we're going to be talking about revenue. So let's look at the column marked individual. So what's going across the top are sponsors. And what's going down the left-hand side, the NHA calls sources. So what I really wanted you to look at is employer-sponsored insurance down the left side, employer-sponsored insurance, and come over to the column that's marked individual. And in that, I wish I had the mouse, but anyway, that number in the individual column under employer-sponsored insurance is 4154. That's $4 billion. The point I'm trying to make here is that you look at employer-sponsored insurance of 15,276 over in the far left column, and you say, well, if we're not going to have employer-sponsored insurance in Oregon with a single payer plan, we're going to need to come up with a lot of money that people are going to pay in new taxes or employer paid payroll tax or something like that. But what I wanted to point out is that 4 billion of that 15 billion is actually being paid by individuals and families now in terms of premiums. And that's different. And in addition to the out-of-pocket, which is under the individual column 2, which is 5.3 billion. So the point I'm trying to make is that I was only previously looking at the out-of-pocket for individuals of 5.3 billion, but in fact, this chart in a good way mixes both the payment for care, but also the premiums. And so we need to keep in mind that individuals and families are also spending $4.1 billion in premiums.
Is Richard frozen on everybody else's?
No, he's not from our end. We can hear him.
And
Yeah.
I'm just about done. The point is that individuals are paying out 5.3 billion in out-of-pocket, but they're also paying 4.1 billion in terms of premiums toward employer-sponsored insurance. Both of those go away under a single payer plan. They'll be paced by taxes, but it's just that there's a lot more that individuals and families are paying than just the out-of-pocket. They're also paying premiums towards that employer-sponsored insurance. So that's all I wanted to point out. Thank you.
I will add that number is probably a little bit smaller, as I mentioned earlier,
Okay.
maybe only 3 billion rather than 4 billion, but it's still substantial.
Yeah, good point. Does anyone else have any either questions or comments on these spreadsheets? John?
Yeah, I would reinforce Richard's message. And it's immediately relevant to the discussions we're about to have when it comes to generating revenue. Because, you know, essentially, again, take the higher number. If individuals are already paying $11 billion, then, you know, in some cases, you could argue that there isn't a new cost to individuals until you get to $11 billion and $11 billion and $1. Of course, communicating that to the public is a challenge, and of course, that contribution, that individual contribution, is paid more by some people than others. I mean, it's probably paid more by sick people than by healthy people. But I think, Charlie, this is a really timely and important piece of information. I happened to read in the Lund report the story about the Providence nursing strike. And towards the end, it reports on the impact of healthcare costs on those predominantly nurses who are on strike. And I probably have this not quite right, but it basically said for the average nurse who makes, I think, around $80,000 to $90,000 a year, the premium and deductibles, they didn't mention co-payments, were almost $10,000 a year, equal to 11% of their wages. 11% of their wages. So they're already paying a significant portion. Now, what they didn't say is, well, what portion of that was the employer paying versus what are they paying? But it stuck in my mind, 11% of their wages. And of course, we're taking that on as a single payer. We're removing that from the employer and we're taking it on. And, you know, the most efficient way likely for it to be recovered is through a payroll tax. So as we look at payroll taxes, we have to, I think, keep figuring out, well, what are employees paying now on their own versus what are employers paying? So, you know, these are very interesting numbers. On your last page, Charlie, I think I'm sure not. I'm struggling to figure out how to do the math on this, but yet, you know, that conversion factor, we know it's around 175 for commercial, 100 for Medicare, and 85 for Medicaid. And so how much of that percent is due to what appear to be very high prices for commercial in Oregon? Because if we normalize that, there's you know, very substantial amounts of money that's transferring. And I think this chart again will be very important in figuring out that normalization impact and what should happen and where as a result of that. So, you know, once again, I think really informative. I'm sure you're not exactly right. God bless you for, you know, keeping at improving these numbers. And I think you'll likely have to keep doing that. But really important, I think, discussion. Thank you.
Thanks, John. Jeff.
Thanks to all the previous comments and the excellent work that's been done. Unless I'm mistaken, on the revenue side, getting a waiver from our federal government to have all the Medicare and or Medicaid dollars come directly into a pool is critical to making this happen, in addition to the additional taxes that will be needed. So please correct me if I'm mistaken on that assumption, but I think we need to keep focusing on that, about that waiver and the need to have those dollars in the pool of money. Thank you.
Thanks, Jeff. I just want to check really quick. I know Chris is traveling, and I want to give you the opportunity to chime in if you can or would like to. So I'm just checking on Chris. If you're able to, come off mute. Maybe you're not. Oh, wait a second. Okay. With that, I do want to check in. I was going to check with Chen Wei too, so I'm going to call on you first and then John. Go ahead, Chen Wei.
I just have a quick comment on the employer contributions. So from that chart, it shows the annual contribution at that time was about $9 billion. That's from private employer. So one of our tasks is, in terms of the payroll tax, how can we design our payroll tax so we can recover the employer contributions? So that would be something to keep in mind.
Yep. Thank you. Yes.
Thanks, Chen Wei. John?
Yeah, Charlie, on the Medicare information in the last slide, any sense of how many of those fee-for-service folks had supplemental insurance?
I can probably get some sense of that. Yes. I think I have numbers for Oregon, but that's not part of the analysis yet, but I will look into that. Because I do have numbers from DCBS of how many are enrolled in supplemental, and also estimates of what the expenditures from supplemental are. So yeah, I can probably put that into there. And so these actually include, I'm not sure. I have to look back at the numbers. I think the numbers that I have are just for what Medicare pays and not for what is paid on behalf of Medicare beneficiaries. But I will look into that a little bit more.
And you know, when I first was out and about in a healthcare environment in the 80s, there was a political movement, and Ron Wyden was very involved in it, arguing to the federal government that states like Oregon, who used Medicare much less, should get a portion of what they didn't use. Follow me? That essentially the Oregons of the world were subsidizing the New York cities of the world, because
Yes.
New York was very high, as was Los Angeles. This gets back to Jack Windberg's Dartmouth Atlas and that analysis, and challenging Congress to, hey, when is it going to be time that those folks who are using many more dollars, without, by the way, any evidence that their health was better as a result, pay more of their share? Congress didn't like that, because when you look at it, most of the chairmen of the Senate committees and all at that time came from those places. But you can see in those Medicare numbers the potential to argue that case. So just wanted to put that stake in the ground.
Oops, I'm not on. I was on mute. Janine.
Oh, I just wanted to remind folks that some of the difference about Medicare is our efficiency here in Oregon over the years, and the rates that are paid to this region are often lower because of our early days of managed care that did not predominate on the East Coast. So in other states, the Medicare rate paid. But again, this is all in the purview of the plan design and payment committees purview to think about payment rates. So just FYI.
Thanks for the reminder. We've got plenty to do. Okay, Richard?
Several years ago, we looked at efficiency or utilization of care. And I think the federal government puts the country into like 310 metropolitan statistical areas. And I think Oregon has 6 of those 310, something like that. And we were in those 6 were in the bottom 15 of all metropolitan statistical areas in the country. So we had very, very, very low utilization in Oregon. And that's what John was speaking to. Plus, we're paid at a lower rate. So both of those mean that Medicare pays less money out here. But the low utilization of Oregon pioneers is notable. The second thing I want to point out is that Charlie's spreadsheets keep track of Medigap payments made by Medigap insurance plans. Those are considered in that spreadsheet private because it's not sponsored by CMS, and it's something that an individual buys on their own to cover things that or deductibles that Medicare doesn't cover. So I just want to point out that Medigap in the spreadsheets is under private insurance, not under Medicare. Thank you.
Good point. Thanks, Richard. I want to give Bethany an opportunity to chime in if you would like, just asking, no pressure, but I want to invite you to add any comments if you would like.
I don't have any extra comments right now. Thanks.
Okay, thanks, Bethany. Chenwei?
Just a quick comment about what Richard just made. The Medicare Advantage may contain public expenditure, particularly the Part B, because sometimes some of the Medicare Advantage combine Part B, and Part B is financed by the federal government.
Yeah, that's correct. I was speaking of Medigap, not Medicare Advantage. Over.
Yeah, and I will say that Medicare Advantage, the part that comes from CMS is all attributed to Medicare, to CMS. And it's only the premiums that come from individuals for Medicare Advantage that are considered private insurance. So
just to wrap this up, I would say, given the fact, I think it's the fact that we will have a consultant on board by, let's say, April. It would be helpful for that consultant to have this information, this work that you've done, with a summary on how you arrived at the numbers, and maybe some aha information that you found from this work, just to get them caught up to speed on what you've done. So I think that'd be a good idea to do that as they're coming on board. So now we're going to pivot. Thank you so much, Charlie, for that work. We're going to pivot now to go into revenue. And I'm going to hand it over to Janine from HMA to give us an overview of the revenue options from the task force. So thanks, Janine.
Sure. You want next slide? I'm joined today also my colleague Anya Wallach-Rader is on today as well. What today's purpose is just to kind of refresh where the last couple of efforts in Oregon's universal coverage we're looking for new revenue. Also kind of a brief overview of the LROs, other areas they covered with you. And then just a snapshot of some other states and approaches that we found as well, including Vermont, where Anya had worked extensively. So next slide. So the RAND single payer, again, that study was done as part of looking at 3 different approaches, and one of which was single payer. They felt that you wanted to, as we've talked capture as much of the federal and state healthcare programs that as possible. Again, that's dependent on asking permission and getting authority to do that. And the operations committee is going to be looking at waivers just this month as well to start that work. The new sources of revenue in the RAND that they considered in their modeling was a new personal income tax. They like the task force wanted it to be progressive, and theirs was less specific than what was in the task force report version, but they estimated that the tax revenues would increase by about 83%, and that sort of increases. Oregon has a range of tax revenue percentage of your income that you need to pay. That's around 7 to 10, at least it was at the time of the RAND study, which was done in 2017. And they thought that would increase the up to 13 to 18% as far as a percentage of your income. They also felt that to capture some of the employer contribution currently existing, they would put an employer payroll tax, 6.5%, applied to large firms, meaning over 20 or more workers, which they felt was, when they looked at it, was about 80% of the total wages going on in the state. And so in aggregate, the Oregon employers would pay roughly the same amount in payroll taxes that they are currently paying for health benefits. And I'll go into a little more detail on this in a minute. The next slide is the task force recommendation, creating a public trust. They looked at several revenue scenarios. They didn't necessarily promote just one. They looked at a couple, and they felt a payroll tax with rates based on employee wages was important, as well as a healthcare income tax on households with the higher income, meaning above 200% of federal poverty level. They did not recommend. Let's see. I thought I had. They did not recommend or approve any other specific the specifics of how that tax would be constructed, acknowledging that more work needed to be done. So the next couple slides, I kind of put them side by side so you could see kind of where they were similar and where they were different. Obviously, their thoughts were like yours, is that you wouldn't need employer-sponsored insurance in either case. They both felt it should be progressive, and in Rand's case, the payroll tax should be for larger employers. And then the two versions that the task force looked at was a 7.25% for wages above 160. This again is 2022 when this was done, and a higher one for those above 160. And they estimated that they could get 12.3 billion from the employers, which would save them money. On the RAND side, it was an interesting component that I actually had forgotten about, but they felt there should be they anticipated there'd be a pass back in their modeling, that if they were any savings on health benefits in excess of the new payroll tax, over those first 5 years, they would be expected to put that back in to adjust the wages. Just kind of a little more directive in the single payer structure plan that they were analyzing, was to be very specific about that any savings was put back into wages. Next slide. And then on the individual side, pretty much very similar. Obviously wouldn't have to pay premiums except for continuing Part B and D in Medicare. Cheryl, do you want to?
Janine, I just have a quick question on the pass back.
Sure, you can go back to that slide.
Is an example of that the thing that John mentioned about the nurses spending like 11% of their wages on premiums, and so if
So
that
they would
were no longer
more dollars
into their wages, or something, is that
right,
an example?
right.
Of that?
I mean, Yeah, it's much similar when I was on the PEB board about how the governor was able to raise federal, or excuse me, state employees' wages because we were able to cap the rates and keep the costs down. So they put it, so in that case, he put it back into our wages at that time. So the same, this one was just a little more prescriptive in how the single payer was
Yeah,
visualized
like an-
back in
that's-
2017. I just thought it was of interest to you all. Think about, I didn't see it in the task force that they had approached that. They expect
yeah.
go
I
back
don't remember
into,
talking about that, but that seems like an important incentive to me
yeah.
for buy-in, yeah.
Next. So the health insurance tax, as I said, it was a progressive tax in the RAND modeling time of what the structure was of that model. And then it would just they would just increase the rate structure of what you would pay taxes on. The task force was a little more focused in their examples that they looked at. Again, they never settled on it 100%, but they did examine a tapered tax rate based on federal poverty level, which are laid out here. And the higher incomes above 400% would have the greatest burden in terms of an individual tax. They felt it would raise about 9.7 million from households, and again, recommended further analysis. So I'll pause here. Cheryl and I were thinking maybe you wanted to kind of think about whether you wanted to still continue to keep these two types of income source tax approaches in your potential model. But I see a question from Charlie.
I was just going to say that as I would keep these revenue sources, that would be my feeling, but I would change them a whole lot. and change their interdependency a lot. So that I'm not sure if you wanted those kind of comments at this point yet. So
Do others have some thoughts on wanting to maintain these, whether an individual income tax, is that something you want to further consider, John?
Well, I would be in favor of having both of these. Part of the reason for that is Medicare. I mean, a payroll tax is going to raise minimal amounts of money from folks who are on Medicare. And so I think an income tax will be needed there, or a premium. Again, I'm still wondering if in some circumstances this should be a premium rather than a tax, and especially when it comes to Medicare. I do see that folks who are under 65 need to contribute to Medicare over the life of their employment, like we all do now. And so that you get a portion of funds coming in that's going to be invested for a long period of time, and grow and create more stability in that trust fund. So, I think about a payroll tax that will pretty much be focused on people now covered by commercial insurance, with a small component, perhaps increasing over time, because you do have the element of people who aren't on Medicare and working, but will be on Medicare soon. Should they have a little bit more contribution to Medicare? So a payroll tax focused on mainly the employer issue and a bit of Medicare, and an income tax focused mostly on Medicare and Medicaid. So I just throw out those thoughts, but these two are definitely, I think, the two important tools for us to use.
I don't know if Richard, were you next?
No, Chunwei was next.
Okay. Dr. Chi.
Yes, just a quick comment. What John mentioned about to call part of it premium, which is workable, but we have to be aware that economists will quickly point out anything that's mandated by the government is a form of tax. But a country like Taiwan, South Korea, and Japan, they all have universal health insurance, and they call their tax premium. So that's kind of the tactics that, but just keep in mind, economists will point out, even though we might label some of them as a premium, but they're actually taxed.
Richard?
Yes, we mentioned about employer passback to the employee because they're not spending money on premiums, but if they're now being charged an employer paid payroll tax, that's going to offset, especially the idea that the task force said it should about balance what they're paying in premiums. So there may not be that much of a passback if they're now paying an employer paid payroll tax. The other thing that I think that both of
Although
these.
I think, just to clarify that, I think what Rand said is if they saved more
Yeah,
than what they were being taxed. So it depends on where you structure that employer
Yep.
tax as to whether it would be more or less than what they're currently paying.
yeah, that'd be a big win for employees. I agree with both of these, continuing to look at both of these sources. What I'm really concerned about is the self-employed person who doesn't have an employer paid payroll tax to support that person, and they may not be getting any insurance at all, and so they're going to be hit with a big tax that they're not currently paying out. I worry about that. Then I really worry about small employers who don't provide employer-sponsored health insurance for their staff, and there's not going to be an offset there, and they're going to feel the pinch too. So nothing that's new, but those are the two that I'm most concerned about. Over.
And Charlie?
Yeah, I would say the other tax that we should include thinking about is a corporate income tax. And my feeling is that that the amount of money that's raised between the employer payroll tax and the corporate income tax should pretty much come to the amount that private insurers are paying now for employer-sponsored health insurance. And the reason for the thinking about the corporate income taxes, I don't think you can raise too much money from it, but you could raise some, and it would slightly lower the employer payroll tax, and it would hit those companies that actually make profit more than it would those who don't. And so I think we definitely should be thinking about that as well. I also have ideas on how we can make it so that small employers are not hit with a payroll tax, and also that there's no fiscal cliff, unlike what the Rand proposed, where there's a huge fiscal cliff for number of employees. So, but that we can talk about that more when I get into specifics.
And I just wanted to check in with the others who hadn't yet raised their hand. Bethany, Jeff, and is it Chris is the other one? Cheryl?
Yes, that's right.
Any thoughts from Jeff, Bethany, or Chris?
And I know Chris is traveling, so it might be that he's in either a dead zone or can't get.
Yeah.
So.
Yeah. Jeff, did you want to say weigh in here?
Nope, nothing to add.
Okay, comfortable
Thank you for asking.
comfortable with these two sources to be further considered?
Yes, to be considered. My concern is elsewhere, but that'll be for a different time in the agenda or another meeting.
Okay. And Bethany, thoughts?
I'm fine with these two sources. I don't have any other thoughts right now.
Okay. So next slide. So I wanted to just refresh a little bit. The LRO had also talked about a sales tax and consideration of whether you wanted to explore that. Also, healthcare provider tax was raised as well. And that could be currently we have some of that paying for Medicaid at the moment. But that would need to be restructured. And then health insurance plan and long-term care facility assessments currently exist, as we've talked about at earlier meetings. And then they also raised some fees as another approach. I think otherwise we've also heard corporate income tax and possibly premium tax. So some thoughts. Any thoughts about other of these ones from LRO at this point? So I'd also pulled in a couple of states, oh, Cheryl?
I'm one who would like to consider sales tax, and I don't know if it's like a side by side, you know, what it would be without sales tax and what it would be with sales tax. That seems easy enough to do. And I'm pretty certain I remember going through that exercise in the task force. I think it's worth
Yeah, I
revisiting.
think they did, yeah. And the impacts of that versus an individual. John?
Yeah, I just wanted to mention, we did talk on the task force about the healthcare provider taxes because I think we believe those would disappear. I mean, this gets confusing to me because if a hospital is paying a tax, aren't they going to basically consider that a cost of doing business and expect the payer to pay them for that tax? And, you know, I understand it kind of around and around it goes, but when you can send it off to the federal government, you get a bunch of money back. But I'm struggling with figuring out in our situation how we could really expect the delivery system to do that. It's a confusing issue for me, and I know that from some recent reading that the current administration may attack provider taxes in terms of funding Medicaid. So, you know, the jig may be up there. We'll see.
Charlie?
I was going to say pretty much what John said, and to me, it's not a very complicated issue. There's really no reason, if we actually do have a single payer system, for the state to pay a hospital an extra fee so that they can then pay the tax back to the state. And so I think it should just go away. And in many ways, I think, you know, it's really at this point, it's a trick for states to say, yes, we're contributing more to Medicaid than we really are. But it's a trick that every state does almost, I think. And, you know, Oregon needs to be doing it now, but I think when we get our proposal for single payer system, there's no reason at all to do it, the healthcare provider taxes. So
You will have to examine what that means for your Medicaid dollar being able to, you won't have as much federal Medicaid match than to support the Medicaid population. So it will have to be.
well, I would say again that what if we actually have a single payer system and we get a Medicaid waiver, we may not need to worry about that. And even if we did, we were be paying a huge amount in Medicaid to Medicaid, way more than we are now, because presumably the payment rates would be equal to the average rate, and Medicaid would not be reimbursed at such a low rate. So I don't think we'd have to worry at all about how much federal matching money we have, and we'd also be trying to get a waiver. So I think that's not an issue that we have to worry much about, other than trying to get the waiver.
Other comments? So Vermont, and Anya's here if you have specific questions. They relied on a payroll tax, and they that was that they felt would be ERISA proof by having a payroll tax, but without directing the employers to do anything different with their benefits. And a disadvantage relative to other states. Anya, do you want to weigh in at all on that?
Sure. Sure, I would just say, ERISA proof would probably be an overstatement. I don't think we thought anything in our plan was ERISA proof. Everything was probably gonna be subject to a challenge. Ultimately, this plan failed, and it failed because of the taxes. And I'd say there were two things, that really killed it. One was just the level and the governor's feeling. The governor really believed that in this plan and wanted to implement it, but the level of taxation necessary to fund the plan, given the level of benefits that we were trying to provide, was something that he just thought was too much of a competitive disadvantage for a little state on its own. And the other thing that I think hopefully you'll get some analysis over time is the redistributive effects of the taxes relative to the current system. Like, it's one thing to say the current system, it contains this much money, right? And we're just going to swap it out for other sources of revenue, but there's tremendous redistributive effects in there. And so that analysis also brought forth some real heavy opposition to our plan.
And then New York State did float a single payer back in 2018. It was going to be a payroll tax jointly paid by the employers and the employees at an 80-20 split. Tax on income wasn't subject to the payroll tax, missing an X there, such as capital gains, interest, and dividends. So they just kind of protected it so it didn't have ripple effect. Washington State is still in the process of determining what they want to do. Their Finance and Technical Advisory Committee hasn't put forth any recommendations as of this date so far. Next slide. And a sprinkling of international models here. It was mostly through general taxation in most countries, with some out-of-pocket costs paid by consumers, and Dr. Chi can weigh in, but United Kingdom, the National Health Service is a income tax, then the country contributes as well, so they call a national insurance contribution, and then they also support it with a sales tax. Canada's is individually administered by the provinces and territories, so there's some variability across the country. They've earmarked earned income taxes, they call them, and employers pay a revenue-based health tax that varies by province and territory. And then France's is a social security payroll tax, pays for a high 50% of it. There's an income tax on all earnings. They have taxes on the pharmaceutical industry and private voluntary health insurance, which is allowed outside of their universal coverage system, and then some state and national subsidies, state meaning their internal provinces. So we also wanted to just think about some considerations as you think further about these new revenue sources, that if people are taxed heavily and have the wealth, they could, it promotes people, if the tax proposal is too heavily weighted all on the higher income, it could prompt tax avoidance or leaving the state. And then just to realize that no matter what tax you come up with, it's very hard for them to keep up with the healthcare costs. And so that will be a consideration going forward over time, unless there's some healthcare cost constraints along the way. So, next slide, I think, is all the.
Can I just pipe in on that last? I think I wrote that last bullet because that was also a killer in Vermont. If you don't have sort of a demonstrated system for showing that you're going to keep costs in line with the inflation in your revenue sources, you quickly develop this gap. And just in terms of credibility with the community, we had to make the best case we could that we'd be able to do that. But it's hard to be believable in a system where nobody's really achieved that.
Cheryl?
First, on the first point, I've heard that expressed in the plan design committee, that very thing expressed, that first point. Do you think that is a significant challenge that we will need to grapple with? I just am curious what you think about it, Janine.
I think it can be a concern. We see that in Oregon already, if people don't want to pay our version of taxes, so they live in Washington and drive over the bridge. So, and those aren't necessarily the wealthiest, but I think that is a concern. It's a balance of not wanting to overtax those with low income, but not overtaxing also high enough to cause a shift there. Anya, I think this was also your comment. I didn't know if you.
It sounds like something I would say. I would just say, you know, wealthy people hire accountants who tell them how to move their money to avoid taxation.
Yeah, right.
You know, it's a fact, and we certainly have seen that in Vermont. I live in Rhode Island now. We see it a whole lot with people who live a portion of the year in Florida, or they move to New Hampshire to avoid taxes. I don't know how to quantify that, but it's not nothing.
Not trivial, huh? And then my second point was, and I'm glad Chenwei raised his hand, because I really wanted to hear from him. I know I've heard Chenwei talk about this second bullet point, so wanted to hear what you have to say about that.
Regarding the second point about cost control, that's a major issue on the plan design and expenditure. And so far, one method regarding payment has been showing highly effective, but it needs the consensus, is global budget. So global budget has been shown very effective. And the example is from Taiwan. After it implementing the global budget in 2002, it has been quite effective in maintaining a slower inflation rate of the total expenditure. And I have another comment that in the near future, we may want to consider, but not to discuss right now. And it's related to the first point, particularly given that our neighbor Washington is simultaneously developing their universal health plan and financing plan. One thing we may want to consider in terms of particularly employer, the payroll tax on employer, as well as corporate tax on the corporations, we may want to be careful in comparing what we propose versus Washington, because we don't want to chase away some of our corporation to move just across the border because they are deemed more beneficial. That's just one consideration. We may want to consider how much difference we want to be from Washington, that when we know what they are proposing.
John?
Yeah, just one remark about the very wealthy folks. My recollection is that the task force, we looked at, well, how much revenue would, tax on luxury items, boats and mansions and things like that. My recollection was what came back was Oregon really doesn't have its share of super wealthy people. And that at least, doing a sales tax on luxury items isn't going to generate that much money. What I took away from that is I'm not sure we should be driven to a great degree by the top 1 or 2% and what they're going to do. They'll figure it out. I agree with the comments that, whatever it is, they'll figure out how to minimize that. And also remember that if you look at any analysis of who's in the top 1 or 2% of income, it's filled with healthcare folks.
My comment was not about wealthy individual. My comment was about corporations.
Mhm.
That in terms of corporate income tax as well as payroll tax, we want to be careful watching what Washington is doing.
All right.
Same for California. We,
Yeah. Although
we-
California hasn't, as far as I can tell, they're sort of stalled at the moment, and not a whole lot of new work is going on at the moment. So we'll have to keep an eye on them though through your course of your work. So I just threw in slideshows, the references for review. You all are familiar with these, but just wanted to make sure you all had those in one place. I think, I don't know, Jen, are you next or Charlie?
Just wanted to ask, or I just wanted to chime in. I have a regular call with some folks from California, and right now they are all eagerly anticipating a report that is coming out from UCLA that was commissioned by the state that's supposed to give them some information. First of all, I think on their waiver, what they might be recommending in terms of waivers, because that's the first step for California, and give them some additional information, I think, about what they would model for expenditures. So if we get information back from California that they've received that report, we'll definitely send it on to the committee.
Yeah, that's great. Yeah, I just hadn't seen much activity in the committees and stuff recently, so. Yeah, Charlie, did you have something else you wanted to say?
I was just gonna say just a little bit about wealthy individuals. While there are not that many high income people in Oregon, they still make a substantial portion of the income in Oregon. So it's still a consideration we need to be thinking about in some way.
All right, I'll turn it back to Cheryl, and I don't know if it's time for a break or.
Well, yeah, I know that there was a break but I don't know that we need one if our meeting is only going to be 2 hours, so as far as I'm concerned, we can just keep going. But if anyone really wants a break, I will support you. Anybody want to take a break? Okay, let's just move forward then.
Well, it seemed like there was some general consensus to consider a payroll tax and an individual income tax with potentially further exploration, but the other revenue sources, I think there was a push, there was some thoughts about corporate tax, premium tax, and sales tax. Anything, does that sort of capture the thinking at this point? Cheryl?
I was going to ask if it's worth looking into the fees. I honestly don't remember what fees were included. Is that a source worth looking into?
I don't know didn't see in LROs that they had a quantifiable what you could or couldn't collect. I mean, I think the long-term care fee is sort of an example of collection, but I think it's redirected back into the long-term care system at this point. I mean, it's just I think they presented it more as it was a way to collect dollars and do it through a fee, which we see, right? Because a lot of the agencies, there's a fee for a driver's license, a fee for a fishing license. So you can capture money that way, I think was the point LRO was trying to make, particularly. Other remember it differently or thoughts about fees?
Charlie, do you remember?
I would say in general, you're not going to be collecting enough in fees to matter very much. It's mostly going to be a way of potentially discouraging some things that you, I guess, decide are worth discouraging. And it, for special things like long-term care, if that is not a covered service, then it may well remain similar to what it is now. But in general, I don't think you can get much out of fees. So
Yeah, looking at their slides, they had a purpose of the fee could be revenue from consumption of healthcare or a means of replacing copays and deductibles is how they referenced it. John?
I'm assuming it's fair to bring up other revenue sources. Well, we've talked about reserves and the need for funding reserves. But that also brings up the question of, well, what will happen to existing reserves in this transition? Hospitals, in order to get the most favorable interest rate on loans for buildings, are usually expected to have, somewhere in the range of 100 to 200 days of revenue. Most hospitals have 200 days of revenue in reserve. Will that be needed in a situation like this? Obviously, some of the transactions that we've had a chance to witness at HICMO have revealed large amounts of money in reserves of Oregon insurers, including CCOs. And what I'm talking about is, is there? It seems fair that a portion of those reserves would come over to the single payer. That would help in terms of stability, would be available for capital equipment, buildings, etc. It might be that Oregon hospitals wouldn't need to have that much in reserve if they had access to a single large reserve fund at the single payer level. So I believe there's billions of dollars sitting in reserves in various healthcare companies that a single payer will remove the need for. So I just throw that out.
Dr. Chi, are you, I think, next? Or you guys kind of went up your hands at the same time?
Charlie first.
Charlie first. Okay, sorry.
So I think John's point is very important, and for a couple of reasons. I think the reserves are a way of thinking about structures and equipment that is necessary for these entities that we would probably like more control to have by the single payer. And also the transition is going to require some upfront costs, and those reserves are likely going to be, the reserves that are in healthcare entities are likely a possibility for some of those upfront costs to be able to lower the costs that are going to occur in the transition prior to it being actually implemented. So I think it's going to be important to be thinking about those reserves. How to think about them, I don't know, but I think that's a really important question. So stop there.
Dr. Chi?
Yes, thank you, John, for bringing up an issue we haven't really seriously discussed, but in the very near future, we need to discuss that. But I'm talking about a different perspective of reserve. That is, once we establish the single payer system, the revenue side, we also need to keep a reserve. And do we have the data on what is the current Oregon state regulation on private insurance contingency reserve?
I do think some of this falls under operations and transition. I don't think the reserves can be an ongoing new revenue source for the health plan. So I do think it's an important area to look at. I'm just not sure if it's under your purview per se at this juncture. Cheryl?
Because we start from scratch, so at some point, if we are going to have this implemented, we need to start build up the reserve, just like any health insurance.
Correct.
So as the reserves relate to revenue though, how do we talk about that? Like what's even possible? I don't really, I guess I'm just picturing, requiring, these health plans to hand over a certain amount of reserves. Like, is that even possible? And how do we figure that out? Like, do we suggest a certain percentage of the reserves that we could use for revenue in terms of our recommendations? I just don't know where to begin with that topic.
Chris?
Yeah, I'll try to chime in on the reserves topic. I mean, I can tell you what's required on the CCO side. I mean, any insurance company or payer needs to maintain a reserve for incurred but not paid claims. And to some degree, I think that can be developed naturally. Like if, there's some start date, and at that start date, we're collecting tax revenue, and we're also incurring claims statewide. There's going to be lag between those claims being incurred and submitted to the universal health plan. And during those months, the universal health plan would be collecting that tax revenue and setting it aside in a reserve. So that's what we do in the CCO world. There's always a lag. Now, it may not be enough to build the reserves as quickly as you need them. And I think any revenue model we go with will need to support those reserves. And on the CCO side, and I think this is true for private payers as well, there are reserves required under risk-based capital standards that sort of scale with the risks taken on by the payer. So a payer that's invested in risky derivatives, say, would need a larger reserve commensurate with that risk. So I do think the reserve question is important and does factor into the revenue build. And on the topic of somehow extracting reserves from from existing private companies, I just don't think there's a mechanism. I don't know what the legality is there, short of socializing those facilities. And if that's on the table, then I suppose those reserves could be accessed. But in my mind, if the future we're talking about is a universal health plan that's contracted with private hospitals and private clinics, those entities are still going to need their reserves. Their business is just like any other.
Dr. Chi?
Yeah, and thank you for Chris's detailed explanation. I just want to give a very quick background of the state regulation on private insurance reserve. Around in the turn of late 1980 to early 1990, before states started to regulate contingency reserve, insurance company used to invest all their capital they collected as a premium on property, on stock. And then at that time, New Jersey, Blue Cross Blue Shield went bankrupt. And Blue Cross Blue Shield, when it declared bankruptcy, estimated more than 500,000 people suddenly lost insurance. And because of that instance, state government started to regulate contingency reserve, meaning insurance company, when they collected those premium, huge capitals, they cannot invest all of them in stock market or in property. They have to, and this vary by state. That was my earlier question. So each state regulate how many % of your total capital must be safe in a bank account, that as a the fluid bank account, you cannot invest that. So likewise, all country with universal health plan, by law, they also require those financing institution to keep a certain months of total expenditure. That's extra in addition to what they expect to spend. They must have a reserve. And that's something we may want to consider in the near future.
Carol?
Janine, just one quick question on the reserves, and then I have a separate question. So do you see the reserves discussion as something that the consultant will be able to help us with, or how do you see that playing out?
Per the RFP that was out, there was an ask for them to help the operations, transitions committee to think about reserves going forward.
But
So-
as it relates to potential revenue for our recommendation, would we be able to?
Well, I mean, I think your purview is how would you pay for the health plan itself and less about the startup and infrastructure.
Okay.
But that's my read of your charter.
Okay, I just wanted to be clear. Yeah.
So and also the reserves, if you're trying to capture them from these, so say you don't have CCOs anymore and you're trying to capture their reserves. I don't know if that's what the structure will end up being. It'd be a one-time thing, right? Because they would.
Right. Yeah. Mm-hmm.
So I think of the new revenue as an ongoing resource of funding to help pay for the benefits that you're going to be providing all Oregonians.
Okay. Thanks, Janine. And then my other question is, and I'm sorry if I missed this, but I didn't catch it. Were we going to consider a special health insurance tax?
I think that was raised by John earlier.
Oh, okay. I guess.
Yeah, as a premium tax, but.
Oh, is that what that is? Okay, I wasn't. We call these taxes different things, and I'm.
Right. I think what the previous two just to reflect on our overview was that the RAND and the task force called them a health insurance tax, is how they were going to sell it to the public for their individual, the individual's tax. They termed it a health insurance tax in those.
Okay. Thank you.
John?
Yeah, I suspect most of you aren't following the transactions related to Legacy and OHSU very closely. There's two of them. And the Legacy OHSU transaction is the merger between the two. It's the second one that I've felt like I've learned a lot from. Because the second one basically says, well, when Legacy and OHSU have completed their merger, there'll be money left over. And we'll use a formula, which they keep confidential, to figure out how much money that is. And we'll create a foundation out of the current Legacy Foundation that we will basically, i.e. Legacy, dominate in terms of governance. That proposal has resulted in a campaign emerging involving several community-based organizations and foundations that basically say, no, wait a minute. When nonprofits have a change in status, an analysis needs to be done independently of what the monies that are left in terms of what's charitable and what's not. And the charitable reserves have to be protected and used to the benefit of the public. Now, who knows what will happen in terms of that transaction and its approval. One of the things I learned that was surprising to me is, again, most of you probably remember Group Health of Washington. It was a wonderful HMO plan that was born in the halcyon days of HMOs, when Kaiser was born. And it had a very successful run in the state of Washington. But ultimately, they became concerned that with managed care and all the other things going on, they weren't attracting a healthy enough population. And it looked to them like their future was not rosy. And they looked for a acquisition, and Kaiser Northwest bought Group Health of Washington. One of the foundations that's expressed concern actually is the foundation that was created as a result of that conversion. When an independent evaluation was done of how much money there was remaining in Group Health as it was purchased by Kaiser, it was $2 billion. $2 billion. And so that $2 billion went over to this foundation. The point I'm trying to make is I think in some cases there's a lot of potential assets that are out there that, if you are a true believer in what nonprofits are all about and what the community should expect of them, that's a reasonable source of revenue for a single payer, as long as the single payer dedicates it to a subset of activities that are clearly oriented to the community. And I would think that could include Medicaid and the additional funds needed for Medicaid, et cetera. Anyway, my point is, I think reserves of various sorts may be larger than any of us think, and that in the right set of circumstances could be a very important and stabilizing source of revenue for the single payer going forward.
Dr. Chi?
Yes, I just quickly check Taiwan's National Health Insurance law about reserve, and it has a very interesting stipulation that we may consider. So in its National Health Insurance law, it stated the National Health Insurance Administration must maintain between 1 month's expenditure to 3 months, up to 3 months expenditure total as a reserve. So this reserve are supposedly not to spend, but they have to be spent once if the expenditure exceeded the revenue. And then it also stipulated if the National Health Insurance reserve exceeded 3 months of expenditure, that's the time a government need to consider lower the tax. On the other hand, if the National Health Insurance reserve is below 1 month's expenditure, that's the time government need to consider raising the tax. So these are very interesting stipulation. In terms of source, their reserve came from multiple sources, including tobacco tax and alcohol tax, as well as surplus from their operations, and also government subsidies.
Interesting. So the alcohol tax is kind of like a fee.
Yes, alcohol tax as well as tobacco tax.
Yeah, tobacco, right. So we've
And And this were not additional because Taiwan government was already collecting alcohol tax and tobacco tax. It was at the time of implementing universal health insurance. They moved those revenue to the universal health care.
Directed them to the universal health. Yeah, I mean, there is also currently tobacco taxes we talked earlier at a previous meeting inside that's helped to support the Medicaid plan. So have we exhausted our list of revenue sources to be considered, and are there some other questions that you have about identifying other revenue? We've talked about John's potential around reserves, Charlie around corporate tax, with some qualifications from Dr. Chi, not to be cautious considering our neighbors in Washington might be doing something. And then we've talked about a premium tax and having to differentiate that from an individual health insurance tax. Other thoughts to help guide your future discussions about the new revenue sources going forward? Richard?
Yeah, I don't, where we are today is not greatly different from where we were at the end of the task force. And that's not a criticism. I mean, I'm just saying that it seems to me that the next step for this committee is to actually get numbers out on a number of these taxes and then start to build that load on individual personas, so that we can get a sense of what the impact is on, say, a couple where there's one earner with an employer, or where you're self-employed, or whether you're a Medicare age, and that sort of thing, and then look at the various panoply of taxes, so that we're looking at the total numbers. How much would be raised by sales tax or payroll tax, and an income tax, and then we need to have those numbers, and then we need to quickly move out to what would it represent for these different personas, so that we can get a sense of what the load is on Oregonians. Because it's one thing to talk at the top level of 18 billion here and 12 billion here, but it's really, really different when you come down to how individual Oregonians are affected. So we have to really get quickly into the personas. And then, as John Santos said earlier, you got to have two different personas for each persona type. One if you have a good year, and another one if you have a bad year and you get sick or injured. And then what does your outlook go on that? So I'm hoping that either the LRO or somebody can come up and start presenting real numbers on this, so we can start to think through it at a deeper level. Thank you.
I just wanted to remind folks, there are some scenarios in the task force report that you might want to look at to refresh your memories of the on how they ran how it would have impact some people at the rates that were presented in there, just as a baseline. And part of your future consultants are also, that's their job to help you do in partnership with LRO. I think Charlie is next.
Yeah, I think before we get into the kind of things that Richard was talking about, we need to have serious discussion about the nature of these taxes. I mean, not just the size, but the nature of them. And I have a whole lot of thoughts about the nature of them that I would like to go into at some point. I would also say that perhaps the biggest question that we still haven't yet gotten an answer from is, can we devise a tax that's based on income that is not subject to the kicker? Because I think that's going to be incredibly important for what we think about. So,
and Charlie, just to clarify, you mean like to confirm you want progressive, that sort of thing? Is that what you mean?
No. I don't know if this is the time to talk about it, but the task force recommendation was double taxing income, which I think is a terrible idea. And so there's ways that you can have a payroll tax and an income tax and not double tax payroll income. And we should be talking about that. There's also ways of making helping out small businesses with not that may not pay taxes now for health, or may not pay for their employees' health care now, and without having it this cliff. And we need to talk about all those kinds of things. And we have not yet gotten into that, but I think we need to get into those sorts of details at some point.
Cheryl, turn it back. Okay.
Yeah, I was going to say, I think both Richard and Charlie have presented a good segue to our next steps, but I did want to check with Jenny on that kicker question, because I believe the last update was that you were going to check with, your legal counsel, and I wonder if there's any update on that really quick.
We do not have an answer yet, but I will send back out a message today.
Okay, thanks, Jenny. And I know we have a couple of other hands raised, and then I do want to pivot to next steps. And you all have already suggested a couple of things, so.
I think John next.
Actually, I think Richard was.
Charlie,
So much for my Zoom telling me who's next.
so Charlie, what do you mean by double taxation on payroll tax, which employer paid, and income tax? I mean, how is that the kind of double taxation you're speaking of?
Yes, the income that is made by employment, if you look at what the task force recommended, was taxed both as an employer tax and with an income tax. And to me, that is absolutely not what we should be doing.
But the employer paid that side of the tax.
Whatever the employer pays comes out of what the individual makes for the most part.
Totally get that, and that's why employer-sponsored health insurance comes out ultimately out of what.
Right. And so we don't want to be taxing wage income twice and taxing unearned income only once. So there's ways of getting around that, and we should talk about that. And that would be among the next topics that I think we should go into. So,
John?
Yeah, I would just like to reinforce Charlie's comment about the kicker and its importance, because, we talked about medical inflation being consistently higher than regular inflation, and how we would combat that. And at least, I think in my head, what that suggests to me is the kicker would make that almost impossible. Because almost everything you do to try and lower that gap, every 2 years, the kicker would just, put you back, move you back. And so I just agreed that if there isn't a strategy to get around the kicker for this important exception, then we really have a challenge.
Agreed. So with that, I'm going to pivot to next steps. And I want to ask first just a clarification question of Jenny. So to the financial modeling that Richard was discussing, we can count on the consultants to help us with that, right?
Yes, that is part of what is in
For their work.
the
Okay.
statement of work for the consultants.
good.
The financial and revenue consultants that we anticipate having on board probably within the next month or so, probably in March, hopefully.
Mm-hmm. Thank you. Just wanted to make sure.
Yep.
Okay, so given our discussion, let's consider what information we need to move forward with our revenue recommendations of the next meeting. And to help us do that, we wanted to take a moment to look at the work plan tasks, where we are, what we've completed. So the staff came up with this chart. These are our committee tasks on the left. This is where we're at. So we've developed a list of attributes and the principles, of course, as you know, that's completed. Review and understand current health spending in Oregon. We feel like we're at a good place right now. I know it says preliminary, but we're needing to move to revenue and maybe pick that back up later. We did not review methods of revenue collection to withstand an ERISA challenge. So we need to pick that up. We did review, update, and build on revenue options, and we just did that more today. So we feel like that's completed, and then we've got all of those other things that we need to work on. So as you look at that list, maybe this will help inform information we need to get going. And then I just wanted to throw in too that we had decided to devote most of a meeting to administrative costs. And I think I may have, I'm not quite sure how we changed our schedule, but I think initially we wanted to have our regular meeting earlier so that we could build in some time before the board meeting so that we could get some, if we had like a straw proposal or if we had something else that we wanted to ask the board or tell the board, that we'd build in some time so that it could be posted on their agenda, et cetera. So I don't know how you feel about having this administrative costs meeting on March 4th. That's what I had thought of in my mind. If we have the key informants ready to go and able to meet with us. And then we have on our list of tasks a revenue straw proposal in March as the consultants coming in. And then thinking that the consultants would start at least by April on the modeling. So that's kind of what I have in the very near future in terms of milestones that we need to get to. Charlie?
I don't see anything on here talking about what I think is an incredibly important topic, and that is the nature of the taxes. So I'm not quite sure how that fits in with things, but to me, we need to be talking about it really soon.
Okay. Does anyone have an opinion about whether that would fit in with any of these committee tasks?
Absolutely. I'm concerned that if we wait for the revenue consultants to come on board in March, and then it takes them 60 days to write up a plan, we're off into June, and we got to get going on the taxes. So any important conversation we can have about the nature of taxes, I'm intrigued to hear what Charlie has to say about that. I think we need to get into it right away to start surfacing the major issues even before consultants come on board.
So if we have consensus on that, what information would we need to have that discussion and have some recommendations?
Well, so let me propose, I don't think we need information. I think we need to be talking about it. We need to talk with each other about what we think. At least I think we have a lot of information. I mean, other than what I mentioned about the kicker piece, I think is incredibly important. But other than that, I think we mostly need to talk about it, and we need to be discussing and try to figure out, well, what should that nature be? What could we do? It's not so much information; it's we need to talk about it.
So what we probably need to do though is to have the information in one place and some key questions, because not everybody is well versed in taxes, and I would include myself in that.
But this is not about that sort of thing. This is about what the nature of the taxes should be, not. I mean, it's a different sort of thing than we have questions about it. We have notions we need to talk about.
Okay,
So
Jenny,
if I could jump in for a
yeah,
second.
go ahead.
In order for us to have a conversation about the nature of the taxes, first of all, we need to understand what you mean by the term nature of the taxes. So you said that the task force was double taxing income, and that there are ways to have a payroll and income tax that does not double tax, that doesn't lead to double taxing. I am quite sure that I don't fully understand what that means in terms of the nature of the taxing. And I'm guessing that some other people on the committee might not either. So we need to understand how we can frame this conversation to get the right information, to bring everyone up to speed on the conversation that we're having so people can participate and know what they're trying to think about. So what information do you think we need, Charlie, to sort of frame
Well,
what the conversation is?
I can provide some notions, I guess, and you can then figure out what information people need. I'm not quite sure how I would do that, because I was hoping that that's what this meeting would be about, is we would be talking about that sort of thing. But I can provide in writing some information about what my thoughts are, and I guess others can look at that and say, well, what information do we need to discuss those thoughts? Because I don't know what you would need to discuss them. And to me, it's like, well, we just need to discuss them, and that's what we need to be doing. So I could say a little bit more right now, or I could provide in writing for our next meeting. But to me, we need to have on the agenda something about that. And I don't see that moving forward. I think it's,
Okay, yeah, Charlie, if you could share some thoughts now and then put it in writing so we understand, because we are not all on the same wavelength here. I can tell you that. for sure.
okay.
So,
I can-
Jenny and I mean, Jenny said in more detail what I was trying to tell you. So if you
Okay.
could offer some things right now, and then I think maybe Richard wants to add. Go ahead.
Yeah, I'll very quickly say a couple things. One of the things I think you could do is have a payroll tax, and then on the income tax, the portion of the payroll tax that is paid on behalf of the individual is taken as a credit, and that way it's not double taxed. So that's one of the things I've been thinking about. Another thing that I think is useful on the payroll tax is to you have the payroll tax, and essentially the employee pays it for each individual like they do payroll tax now. But they, some amount of the income that the individual makes is not counted, and either that's a certain fraction or it's maybe a fraction depending on dependence or W-2 form or whatever other ways we can go about it. But you could also say that for the employers, the first amount of some amount of payroll has no tax on it. So like the first $500,000 of payroll, you don't pay any taxes on it. And then there's a marginal tax rate after that point that is paid for the employers, and that marginal tax rate is or the total taxes is portioned between the employees so that the tax credit can be determined for each employee. And the reason for not taxing a certain amount of the first amount of payroll is that then small employers with maybe 1 or 2 or even maybe 5, I don't know, it depends on what amount, don't pay any payroll tax. And that helps those small employers, many of whom, actually most of whom, do not provide taxes for or provide health care for their employees. And so, but the other thing that does is basically on the amount of payroll and not the number of employees, is you avoid fiscal cliffs, which I think is incredibly important. So those are just some of the basic ideas about that I say are the nature of the tax system.
Okay, thanks, Charlie. Richard, did you want to add anything?
I get the idea of kind of a threshold for small employers. I think that the idea of a credit against a personal income tax for what the employer spend. I mean, we're talking about squeezing a balloon here, and if we diminish the employer payroll tax, it's going to increase income tax. And I know you know that, but to not have the two both be paying in on the same individual. It seems like would dramatically increase income tax rates. I know we're just talking in general and not specific, but I'm really concerned about that.
I mean, yes, it would increase income tax, but I think that's necessary for what we need to do, because I do think that it's very important to get taxes from those who make unearned income. And so I think that we need to be cognizant. So this is the sort of discussion I think we need to have. And we need to at some point put some numbers to it, but we need to have some specific ideas of how these things could work. And so I will put it a little bit more in writing.
Yeah, that'd be helpful. Thanks, Charlie. So Richard, did you have anything else before I ask anyone else?
I think the other concept out there is that whether you're wealthy or whether you have high income or low income, generally across all circumstances, your healthcare costs are roughly the same. Meaning, if you were to insure people regardless of income, I mean, I'm just making it up, but for a family, you might be paying $25,000 or $30,000 would be the premium cost to cover that family. So if you earn $1 million, it still might be $25,000 to cover your family. If you make $40,000, it still might be $25,000. So I think another concept is there a cap on how much income tax we'd have, because it so grossly exceeds the cost of that healthcare. So again, that's kind of counter to the unlimited progressivism, but that's another concept.
Okay, thanks, Richard. Does anyone else, any other committee members have comments on this particular issue before we try to tee up what our next meeting will be about on revenue? John?
Well, if I understand Charlie's use of the term, the nature of, to some respects, my earlier comments about Medicare would be appropriate to discuss. I mean, for example, could you identify what are going to be the costs of the additional benefits that Medicare folks would have, i.e. dental, vision, hearing, etc.? The fact that they will not pay any co-payments or deductibles. The fact that the process of normalization will mean additional costs in Medicare to bring up Medicare payment rates. And what would the cost to consider that a, if you will, Oregon Medicare Part F? and it's a premium, but I understand it's a tax, because in order to get it efficiently, you'd probably need to use the tax system. And you know, you could put some degree of progressivity into it. So lower income folks would pay less, higher income folks would pay more. And so separate, if you will, Medicare from that, knowing that realize people with Medicare in Oregon will have to enroll in Medicare. They will have to pay their Part B premiums and D, et cetera. So it still is going to be a different kind of very federal oriented a relationship for those folks. You know, and that people under 65 could be assured, other than this modest, you know, contribution to Medicare that you're making for your future Medicare coverage, you're not subsidizing Medicare folks. They're paying their way. You know, I don't know how that would all work from a math point of view, but I think it's worth looking at. So that I think is within what Charlie's talking about.
And John and Richard, if you would like to clarify, you know, questions or thoughts for us, that would be helpful too, just to frame up this discussion in writing. That would be helpful for us. Does any other committee member have a suggestion, or it looks like Jenny has her hand up?
I just wanted to also say, if some of the other committee members also who haven't sort of jumped in on this conversation, maybe because this is a little bit more in the weeds than a lot of people have gotten to this point in terms of considering what the taxes look like, I would really encourage you to, if you want to send in questions to sort of clarify your thinking on this or your understanding of this, or the questions you have about what's being considered here, I would really welcome those, because I think that can also shape the conversation so that we can answer some of the questions to bring everybody into sort of onto the same page, to start having a conversation where we're all looking at this from the same perspective. And I do think that it is part of the consultant's work once they come on, as we're looking at the updating and building on revenue options. That's not just the category of revenue, but also what are the options within those revenue categories. If I'm understanding what you're saying, Charlie, properly, I think you want to dive in a little bit deeper than we're looking at payroll tax. What are the different ways that we can consider payroll tax to meet the revenue source that we need, while also considering how we're affecting the businesses? And so I do think that is part of what the consultants will work on. And I would really encourage anyone to send in questions you have about how a payroll tax would work, how an income tax would work, so that we can answer some of the questions that I think maybe we're not all asking, because either we can't conceptualize it at this point, or we feel like everybody else knows the answer. So please, anyone who has questions, please send those in, or clarifications or things that you'd like us to start scoping out in order to get those questions answered.
Thanks for adding that offer, Jenny. Appreciate it. So with that, I'm just trying to, and I just don't know the answer to this. Is it possible to, could you go back to the last slide just so I can look at what we've missed? So is it possible to have a meeting where we pick pick up the ERISA challenge discussion and talk about these the nature of the taxes, as Charlie mentioned. Is that possible? Can we have both of those discussions, or do we just focus on the taxes first and pick up ERISA next or later? Charlie?
I think at the next meeting, one of the things you were wanting to talk about was having the panel provide information, and so
Right,
that will be, I think, I'm not sure if that's the only thing, but if we do the panel and sort of the nature of the tax discussion, I don't think we want to put ERISA in with that.
right.
If we do, if it's a separate meeting where we're doing the nature of the taxes and ERISA, I think we might be able to put them together. I think the ERISA challenge is, I mean, I don't really think there's that much we can talk about there. I mean, primarily it's, we think that we can do something with payroll taxes and have a better chance of surviving an ERISA challenge than if we did something else. And so I'm not sure at this point, for our purposes, there's much more we need to be talking specifically about ERISA. And again, ERISA laws could change by the time we try to make a proposal. So
Yeah, that's true too. Richard, and then I want to kind of wrap this up.
Yeah, but we just did ERISA a couple months ago. Janine presented that, and I don't think there's anything new on the ERISA front. So I'm wondering, why is ERISA coming back up at this point? There's nothing new to discuss, that from my point of view.
yeah.
Okay, well, maybe we'll talk with Janine and staff and just see what we need to do on that. And the other thing is, if you can give us a little flexibility, we'll see if we can get that panel together for March 4th. And if we can't, then that'd have to be bumped to the other meeting in March anyway. And so if we have some flexibility, knowing that maybe the tax discussion is half of the meeting and the administrative cost is the other half, or then we fill in with something else. So we're just gonna have to have a little bit of flexibility in March, depending on whether we can get that panel together, earlier or later. So we'll just figure it out. But so let's move on. I know we have one public testimony, and I believe I am going to call on the person, so, or public comment. Just a second. So it is Richard Walsh. Are you with us, Richard?
Here. Yes, I am. Can you hear me this time?
Yes, we can. Thanks, Richard.
Yay.
Go ahead.
I tried doing it last time and it didn't work. So I'm grateful that the audio works.
Yes.
Thank you very much for everybody. And I really appreciate all the time all of you are putting into this. This is a very important thing for you to be doing, and we are very grateful. I have 3 hats that I have that I'm wearing, and I want to briefly go through it. One is I'm with the HCAO, the Healthcare for All Oregon organization. And I just want you all to know that you're not alone in this. We're here to help. There's many people that are watching that you're seeing on this on the feed. Many of them are from HCAO. And so if you need to discuss things, I know you can't talk to each other, but you can talk to us. If you need help, we can help. There's literally thousands of volunteers that said they want to help. And so we're the group that you can tap to do that. So that's my first hat. Second hat is I'm a lawyer, and I've been representing injured workers for over 35 years. And I've dealt with this current system. I know how bad it is to the people. My biggest concern there is a loss of freedom all my clients suffer when they have to stick with their job because it's employer-based for their health insurance. And it's just the hugest tragedy you can imagine, having to live a life of pain. You can't even imagine the loss of freedom people suffer. And I think that resonates with a lot of people. My third hat is I was a Democratic nominee for the Oregon Senate District 11 in 2022. And in that role, I talked to hundreds, if not thousands, of Oregonians about healthcare for all. And I learned that Oregonians will support healthcare for all, but you have to do 2 things. One, it has to give the same or better benefits than they currently get. Most people are insured in one way or another. And that's satisfied if you just get the PEP benefits. So as long as people know they get as good as the governor gets, they're good. So that's taken care of. Number 2, it's got to cost them less than they currently pay. And I think this goes to the whole issue that was brought up by one of you earlier about redistributive problem. It doesn't matter if it costs less to someone else or costs less in general. If I have to pay a lot more than I currently pay, then I become an opponent. That's what people do. And to do this and to keep this, I think to make this work, you guys have to focus. You already know this, and I really admire how you're gathering all the resources of government together. I did a quick Google search and I kept saying, well, what else to the AI program? And it kept giving me more. I got over 35 programs that we're spending on healthcare for one group or another. And I don't think you stop at anything. I mean, if we're going to cover everybody, why not go to those resources that are going to everybody from the government? That would include everything. Don't just say, oh, we can't get that one, get that one. There's a whole new government. There's a whole new federal government. Things, all the rules that were there in the past can change. So a lot of energy when you got your resources and your people, try to get them all to gather up all the resources you can in all areas. And once you see all of the money, then you go, okay, because that's what pays for about half of all the stuff now. You should be able to get those in a pile. Once you get that, now you got to fund the other half. The other half mostly is from employers. And I know that's really from employees, but the employers are paying the bill. And so how are they paying it? They're currently paying it on a per person, full-time employee basis. I'm an employer. I have 10 employees. I pay for health insurance for some of my employees that are full-time. And I know that I pay for every full-time employee, I pay about $8,000 some odd dollars. That's the Oregon average. If you could figure out a system where you could charge me under $8,000, if you charge me $8,000 per full-time employee, I win. I make a little bit of money. I don't have to deal with the overhead. Everything's wonderful. I become a big supporter, and I speak for many businesses. If you're worried about businesses going overseas or over to Washington, they'll go, oh my God, you can get per full-time employee, I only have to pay $8,000, not $8,200 or $8,500, and I don't have to have the headache. Great, let's move to Oregon. Make this a draw, not something people are repelled by and run away with all the money that they do, as you guys talked about. So I would really hope that you would put one more option on the table, and that's a full-time employee tax, 8,100, 80,000, whatever. You figure out what the number is, and then if for every full-time employee, if there's that tax, then we don't lose more money. Let me give you a quick example, and then I'll leave. I know my time is running out. I have several employees that make I have employees that make routinely over $200,000 a year. If it's just a simple 10% tax, which sounds pretty innocuous based on everything you guys have been talking about, a 10% tax on $200,000 is $20,000. You don't think people in my situation aren't going to be, putting a lot of money into the opposition if we're paying $20,000 for a health insurance plan when we can pay $8,000 currently under the current plan? You're going to have all these people that really want healthcare for all to be opposing you. In fact, everyone who makes over $81,000 will probably be opposing a plan that's progressive. I know progressive is better and all that stuff, but if you actually think about it in terms of the huge burden on individuals, a per FTE tax will not be regressive. It will actually be progressive because it'll allow everyone to have healthcare for all. They won't have to pay for premiums and so on. Anyway, I can go into all kinds of more detail. I know I don't have time, but thank you for listening to me on this, and thank you for all the hard work you guys are doing.
Thanks, Richard, first for your offer to help us. We can use all the help we can get. Thanks. And your ideas. Appreciate you commenting. Thanks. So with that, it occurred to me that since we are talking about the straw proposal at the board meeting, we will have some feedback on, or the board's feedback, maybe perhaps some questions at our next committee meeting too that we'll discuss. So we'll make time for that as well. So thank you for attending today, and we are adjourned.
Thank you.
Thank you.